Okay, let's go ahead and get started. My name is Alan Schroeder. I'm from Pediatric Critical Care and Pediatric Hospital Medicine, and have been helping to organize this series along with Dr. Rajni Matthew from Pediatric Infectious Disease, which started this actually last fall. And for now, at least, this is probably going to be our last session, at least for the indefinite future. Perhaps we will have another in late summer or fall, depending on the need. But I see that as partly a good sign that things are moving forward. Obviously, still a lot of lingering questions, and we want to be that resource. Housekeeping wise, this is the text code for CME credit that will also go into the chat. And please do submit your questions into the Q&A function so others can see rather than the chat. And we will try to get to as many of those as we can today. We also had a number of questions pre-submitted prior to the session. We will try to cover those. I would like to introduce our speakers. Baraka Floyd, many of you know, was one of our former residents and is now a clinical assistant professor in general pediatrics, and is going to reflect a little bit today on her experience in primary care, as well Anita Juvvadi, who's one of our general pediatricians through the Packard Children's Health Alliance, and has also been on the oversight committee of this series, so we've appreciated her input and has been a guest in the past. And then lastly, Grace Lee, who is a professor of pediatric infectious disease here and has a number of national roles, most notably as a member of the advisory committee on immunization practices, the ACIP. So, and actually Grace Lee has to join a 12:30 meeting for the ACIP today. So we have a precious 27 minutes of Dr. Lee and really want to pick her brain and take advantage of her experience to understand what's going on with immunization. Largely today, we will focus on immunization of children. So I think you can unshare now, Ingrid. Great, thank you. And thanks again to all of our guests for joining. Dr. Lee, we'll start with you. And I think what several of the questions that folks submitted beforehand, what many people are now talking about and a little bit worried about, the report from Israel on Tuesday about myocarditis and pericarditis has generated a lot of conversation. I'd like if you can just start by reminding us a little bit about what the ACIP does, and then we can discuss a bit more about these concerns.
Yeah, thanks so much. In brief, and I should just disclose that I have no financial disclosures. I am a member of the ACIP, as Dr. Schroeder mentioned, and I actually also happen to chair the vaccine safety technical group focused on COVID-19 vaccines. So I'm happy to share a little bit of the overview and the experiences. In brief, ACIP is a federal advisory committee that provides advice and recommendations on use of the U.S. Vaccines in the U.S. civilian population. And those recommendations are provided to the director of the CDC. The Federal Advisory Committee component is important because we do hold all of our meetings in public. And so there is a chance not only for the public to hear the deliberations as they are going on in real time, as it has been all year with COVID, but also the opportunity to provide public comment. And so both of those functions are really important to us, as we see our role on the committee is really serving the public and the US population. In terms of specific roles, we have work groups, of which I serve on the COVID-19 vaccine work group, where we deliberate and go in depth around all of the data that's coming in around the benefits and risks and the benefit risk assessment of vaccines, and that is specific to COVID-19 vaccines. In addition, what's different about COVID-19 vaccines is that we actually have a COVID-19 vaccine safety technical work group that was stood up specifically for COVID-19 vaccines, in part because we have the opportunity to review on a regular basis all of the data coming from the federal vaccine safety surveillance systems. So we have met, I've lost count of the number of times, but just since the first vaccine was approved for use on December 12th, 2020, I believe we've met over 25 times already as a group. So meeting essentially on a weekly basis to review all the data coming in from these systems. These systems include the following: VAERS, which is a passive reporting system. Anyone in the US can report any potential adverse events of interest to CDC and FDA through the VAERS system, and happy to put in the information online at the end. The second being the Vaccine Safety Data Link, which is a closed population-based system that includes a lot of California Kaisers, but some other Kaisers across the country, as well as Marshfield, Harvard Pilgrim Healthcare, and a few other sites. We also rely on what's called vSafe, which is a text messaging-based system stood up specifically for COVID-19 vaccines to monitor vaccination safety and like the health of vaccinees after vaccination. I will just put in a plug that although vSafe was originally built around the adult population, there is the opportunity for parents to enter data for their teens or for anyone who's approved for use of a vaccine. So after you get it, you can actually report in initially on a daily basis, then weekly, then quarterly on what's going on. And that system has expanded to now include pregnant women because although there was no specific recommendation for pregnant women, we wanted to ensure that pregnant women had access to vaccines that were available, particularly given the risks associated with COVID-19 infection during pregnancy that we have seen. And over 100,000 women actually have reported into vSafe that they are pregnant and had received COVID-19 vaccines. So there's now a pregnancy vSafe registry that has been adapted from the original vSafe registry. In addition, we capture information from CMS, from the VA, Veterans Administration, from the Department of Defense, and from the Indian Health Services. So we are regularly and routinely looking at all of this information to monitor vaccine safety in real time in the US as the information is coming in. Some of the role of that particular committee really is focused on risk assessment. We work closely with the COVID vaccines work group to talk about benefit risk assessment, and all of this information obviously goes to the ACIP, the full ACIP, to really think about decision making and how benefit risk assessment plays in that decision making. So that's the overview. I'll just go briefly into VAST, and the role of VAST for us has been, we've been very fortunate to work with all of the expertise across the federal vaccine safety surveillance systems to monitor adverse events, both those that had been pre-specified far before we even had the first vaccine dose out, as well as any unanticipated potential adverse events. So a great example initially was anaphylaxis, which we saw initially after the vaccines were rolled out. And that was a great example of how our vaccine safety partners really captured that information, provided as much granular information as possible, and then actually supported all of us in our vaccine programs to ensure that we were safely delivering vaccines and taking care of patients in an expedited manner. So that's one good example. I'd say another example of that would be TTS, or and I'm going to forget the acronym, thrombotic thrombocytopenia syndrome, which is these unusual clots that were observed following the Janssen vaccine in younger women, so those women under 50 years of age. Originally seen in Europe and Australia, I apologize, with the AstraZeneca vaccine, so adenoviral vector vaccines. And as folks might recall, there was a safety pause put into place on April 13th by the CDC and FDA, and then we quickly gathered and reviewed the information around what's now known as TTS in 2 ACIP meetings that followed, and specifically reviewed all of the information, again, in a public setting so that folks could deliberate on this, and the benefits and the benefit risk assessment. So now, Alan, you asked about myocarditis, which is sort of the latest thing that we're working through right now, and I'd say working through together. And I will share, or maybe somebody can share, there is a link to the CDC website where our work group, which is called VAST for short, the Vaccine Safety Technical Work Group, has been posting or presenting publicly in ACIP meetings all of the information since December. It's been a little while since we've had an open public meeting because there haven't been any decisions. So we've been fortunate in that we've been able to communicate through this website to be able to share some of the discussions that happened during VAST. And on May 17th, one of the items that came through specifically was that we did review information from our vaccine safety surveillance systems. And although there were, again, similar to the very small number of cases with TTS, had a small number of cases reported in a potential myocarditis plus or minus pericarditis that was seen predominantly in young individuals, so adolescents and young adults. They seem to happen more commonly in males over females, which is also known to myocarditis in general is known to have a male predisposition, and then more often following dose 2 than dose 1, and then typically within 4 days after vaccination. And although there weren't enough cases, although the systems at that time we're not really picking up any routine, what we call safety surveillance monitoring signals, it was enough for us that we wanted to make sure that there was awareness of this, both for our clinician partners as well as for the public, to be able to share this information so that folks could be on the lookout for it. On the plus side, what's described on the website is that most cases appear to be mild in that individuals are hospitalized for a very short time. Their symptoms and labs seem to resolve quickly, and then we're continuing to have ongoing follow-up of cases. But again, feel very strongly that transparency and communication is part of our role. Since then, we've had a couple more meetings, and then CDC actually put out, and I believe those are now in the chat, some information specifically from the CDC about myocarditis and pericarditis, as well as, if you look to the clinical considerations, if you're a clinician, some additional information for clinicians to think about when seeing kids. I'm talking to pediatricians right now, pediatricians who see kids, and or our adult colleagues our family practice colleagues who see young adults. So would really encourage folks to take a look at that. I would say this information is evolving. We continue to update our clinician community and the public. And I think, the biggest question we have right now is just putting numbers on it to be able to provide a more robust assessment and clearer communication around, what are the risks and what are the benefits. I'll say as just a quick side note, and then I'll pause and, happy to turn it over to others. Just that the manifestations that we have seen with COVID infection in teens and kids has been substantial. So we talk a lot about how it doesn't look like what we see in adults. However, Dr. Matthew and I, having seen kids on the inpatient service, and I'm sure Dr. Schroeder has too, can attest to the fact that sometimes the consequences can be significant, and actually cardiac consequences following COVID infection can be substantial. And so I think it's important to remember that in the context, a lot of decision-making really is benefit risk balance. And my brief anecdote is I also have somebody, my own child who's in the 12 to 15-year-old age range. And this is evolving. We are going to learn more information. But I, personally, my own decision has been that knowing what I've seen about the consequences of COVID infection, that for me, the benefits far outweigh any risks, and we are going to have better information about what the quantitative assessment will be. But qualitatively, I feel pretty strongly that I still want to make sure that I can, protect my own kids. So that's my endorsement in a very qualitative fashion, and I'm happy to turn it back over to others.
Well, I appreciate you sharing that last part, and my son is scheduled for number 2 tomorrow, so I was glad that we had an opportunity to discuss this now. One of the things that I'd like to get to in a second is this question of just postponing the second shot, which a lot of people are now at least suggesting is one way to think about this concern. But let me just go back a little bit and make sure that we're summarizing at least what we know now correctly, and that is that the Israel data at least is modestly concerning in that there was certainly seemed to be a signal of a higher proportion of cases shortly after the second dose and predominantly involving young male adults. But as far as what we've seen in the US so far, although there, at least if I'm understanding correctly what the CDC is saying, there was perhaps a slight uptick in reports to VAERS, but when you look at the vaccine safety data link, which is probably a more accurate representation of comparisons of vaccinated to unvaccinated individuals, we're not yet seeing a signal there. Am I summarizing that correctly?
What I would say is that, sorry, I'm stuck on the VSD comparison. So actually the VSD compares vaccinated it has a vaccinated to vaccinated comparison, but within different windows. And it also has a vaccinated to unvaccinated comparison. But what I would say is that the Israel experience that's come out, I think in many ways their vaccination program went very quickly for their entire population. What we're seeing now is that we have primarily rolled out in the older adults and are moving downward in age. So we continue to monitor the situation carefully. I anticipate we'll have more information in the next few weeks is my hope, that will be able to be easier to understand or quantify those any risks that may occur. What I will say is that mRNA vaccines are unbelievable in that because they are so immunogenic, they're highly protective. I mean, so if folks will remember back to this last summer, we thought that the vaccines, we would be lucky if we got 50% efficacy. We're seeing like over 90% efficacy, and in effectiveness studies, those numbers bear out after 2 doses. So that's been like a huge blessing for us. And I think that also explains why we are where we are in the pandemic now, with the numbers continuing to look better, with a greater proportion of the population vaccinated. And in the Bay Area, we are extremely lucky that we have a highly vaccinated population, and our numbers continue to remain good. That said, we also recognize that reactogenicity as part of that immune response is pretty robust. And I think what we're doing is we're learning about that. There's something different about, I think from my perspective, COVID in general, where it in and of itself as an infectious cause of, we focus a lot on respiratory symptoms in the adult population, but clearly it has a significant post-infectious inflammatory component that we still need to understand, with MIS-C being the best example of that and the most severe example of that in our younger kids. I think we need to be able to disentangle, how much of this is related to COVID in and of itself, and understanding again the relative benefits and risks. The other thing I'll just really highlight is that there was a publication in JAMA Cardiology earlier this week that did follow the athletes. So you'll remember in the fall, there were some athletes who were closely followed and ended up having myocarditis after COVID infection. And they estimated that approximately 2% of their individuals who were COVID infected developed cardiac pathology. So that's 2 out of 100. And at this point, we've vaccinated, how many vaccinated? I want to say like we're over 260 million doses in the country, and we need to focus in on sort of the younger adult population. But we are many, many millions of doses in, and are just starting to see this now. So I think that just trying to scale the two is important to sort of put into context.
I mean, and talk about that a bit more. I mean, we've had hundreds of millions of doses, and there really were at least life-threatening concern from this vaccine in terms of myocarditis. It's hard to imagine that we wouldn't have seen something more striking here in the US at this point. Would you agree with that?
Well, what I would say is that it's our job to remain vigilant. I think that as part of vaccine confidence and ensuring vaccine confidence, we have to closely monitor vaccine safety so that doesn't go away, even though we're like, over 200 million doses in. And so that I would say is, yes, we are many, many doses in, and to date, we're just now starting to hear about these things. The other thing I want to point out is that our pediatric colleagues at other institutions are really where I first heard about this. So I want to give credit to our really astute clinicians in our communities and in other areas of the country who really kind of put this together. So even despite the hundreds of millions of doses now that we've administered, it really, I think I just want to give full credit to the clinicians who really were aware and mindful and thinking about this and raising this as a potential issue for us to monitor. We're monitoring it closely, and we'll continue to learn more over the next few weeks.
Okay, and so currently, at least, the CDC, the ACIP are continuing to encourage vaccination in 12 to 15-year-olds. Any suggestion about the timing of the second dose?
What I would say, well, so I've been asked this question multiple times, and there are our recommendation is still the same, which is try and receive it within the interval. But obviously, no one usually hits it perfectly on that interval of Pfizer vaccine currently being available for the younger kids of 21 days. But we try and do it on the shorter order rather than longer order. I can only speculate. And I think what we'll learn more about this in that the vaccination patterns are different in different countries. There's two things I'll just point out. So first, it's really interesting because if we look at other childhood vaccines, and I'll give HPV as an example, what we have learned is that younger kids can produce a pretty robust immune response, and that the longer you wait, sort of the more that you have the ability to mature that immune response. So waiting might actually waiting may or may not be helpful in this instance, because you would expect the longer you wait, the more mature your immune response is to dose one, and whether or not there's any change in how much inflammation there is around dose two. I don't know. We don't have that information, but I think it's a good question to ask. But there is evidence from other vaccines to suggest that a longer interval might result in sort of a more robust immune response. I guess the second point I'll make is that the one thing, I've been asked a lot about boosters, and I've been really impressed with the durability of the immune response of our vaccines in general. And to me, really, the need for a booster comes into play with the variants. And what we do know is that there are a minority of variants circulating in our country. The majority of variants that we're seeing, fortunately, our vaccine continues to be quite effective against the most commonly circulating variants in the US. But it is a matter of time. The virus is smarter than we are, and it's just a matter of time before it figures out a way to establish itself such that it will succeed. And so I think the other component of this is I am glad that in the US, we continue to keep the tighter interval, because I think that boosts our ability to reduce the circulation of variants in our country. And we're going to continue to need that 2-dose protection to retain that high level of efficacy after a single dose. And in countries where I think they're waiting much longer between doses, I worry a little bit about the fact that there's imperfect efficacy with variants circulating and what that means for the spread in the population. So I think we're in a good place now. I'm going to remain optimistic that we're going to stay in a good place, but I think we just don't know how quickly things will evolve with regard to variants. And that's where I think the question about a booster comes in, is really if, for example, there are variants in the future that where our current vaccine is not as effective as it has been against the current ones that are circulating predominantly, we're going to need to think about that. So I put that in your thinking cap, mostly because there's multiple competing demands in terms of population and individual benefit risk balance.
Great. Well, this has been really useful and helpful. I appreciate all of your input, and really want to reiterate, I think I speak for our entire community in terms of expressing our appreciation to your involvement with all of this on a national scale. And we have had several questions, just to maybe try to close the loop a little bit on the the myocarditis issue, and then actually Dr. Floyd and Juvvadi, we'll want to hear the extent to which this is surfaced in your clinic in just a bit. But there have been some questions sort of saying that because some of these cases are very mildly symptomatic, if indeed the signal is real, should we be taking any precautions in terms of people who have gotten the second shot and maybe return to sports, sort of aggressive physical activity? Obviously early to know a lot about that at this point, but any thoughts that you have on that?
Yeah, sure. So if you look to the clinical considerations link, in there is, and we've, obviously this is a multidisciplinary approach to thinking about myocarditis, where our cardiology colleagues are, critical and important in really not only helping us think about diagnosis, but also early treatment and then long-term management. They actually, in the clinical considerations, AHA actually has guidelines around myocarditis and return to, sports activities or things like that, that are in there as a guide. I, again, hope and anticipate that as more information emerges, as a larger community, we will have consensus on this. But I would say at a minimum, from what just from a basic principle standpoint, if there's ongoing inflammation or concerns, that I would make sure that folks are seeing a pediatric cardiologist for clearance for those who have a diagnosis of myocarditis. But I think the most important thing is making sure we have awareness in our pediatric community, and this also goes for the adult community because they're seeing young adults, and also some of our kids are often seen in adult ERs. To ask the question, to make sure that we're diagnosing folks in a timely manner. And then from there, I think then the management, we're going to continue to learn about how to optimally care for these patients.
Great. So if you're asymptomatic and you've had your second shot at this point, based on what we know, no reason to limit activity. Right. It looks like we have 2 more minutes of you, Dr. Lee. And I wanted to, can you give us 90 seconds on where we are with under 12 vaccination, what the horizon might look like, what the timing might look like for that?
Sure. So, we are still in the part of the phase where the industry or manufacturers are really thinking about making sure the dosing makes sense for the younger child population. And this is a really immunogenic vaccine. So making sure that it is both similar in terms of your immune response, but also safe is going to be important. So I think we're waiting for the dose finding studies to emerge, and then specifically for the sort of phase 2-3 trials to emerge, where we anticipate that they will study both immunogenicity and safety. We were actually, in the in the adolescent population for the Pfizer vaccine, we had only anticipated we would have really immunogenicity data and less so efficacy data. But as you saw from the trials, it was like a 16-0 split. So they were able to actually measure efficacy, even despite it was 4,000 to 6,000 kids or so in those trials. I'm blanking, sorry, I apologize. I don't remember the number off the top of my head. I have several thousand in the Pfizer trial in my head. So I think that that's really important. So my hope is that we will have more information. All the public communications we're getting are by fall. And what I would also put in a plug for is that I think that, and this is for all of us, to really start to dig in deeper on not only what are the consequences of COVID infection, but really, I feel like we need to have a deeper understanding of the morbidity associated with COVID infection in kids. We have focused so much as a country on the older adult population. I think we need to do some more deep dives into understanding what's happening to children who get infected. What are the long-term consequences? Are we seeing long-haul COVID? How are we helping kids and families manage long-term consequences of infection? And that's going to be really important in our benefit risk assessment as we roll forward whenever we have vaccines that are safe and effective available for use.
Wow. All right. I think we did it. And thank you again. Very much appreciate all of your comments and wisdom. So thanks, Dr. Lee. I'm going to move now, and I want to maybe just quickly, we'll start with you, Dr. Floyd. Tell us a little bit about where you work and what you're seeing as far as acceptance of the vaccine, any concerns, hesitancy, and whether or not myocarditis has surfaced yet as a concern.
Sure. So I work at Gardner Packard, which is an FQHC where a lot of our division of general pediatrics practices. And it's a resident-run practice. So we have trainees who see the patients and then we see them second. One of the things that's been really interesting is we all really anticipated lots of vaccine inquisitiveness to be a barrier for families being willing to even get their children vaccinated. But I've been so surprised by how families have overall been really enthusiastic about making sure that their children get vaccinated, even if they have concerns about safety, concerns about ingredients, concerns about the speed at which the vaccine was created. And more of it recently, in like these last maybe couple of weeks, has been more around getting their children back to normal safely. So not as much around how can I protect my child from the morbidity of COVID, COVID disease itself, but more that they're seeing that their children are really being impacted by not being able to access their usual activities, being able to be around other age appropriate children, being able to go outside. And so a lot of families are very motivated around that, more so than preventing COVID for their children. And one of the things that has been also really interesting is the common concerns have been kind of very variable. So the one that comes up the most often has really been the speed that the vaccine was produced in, and being concerned that this might mean that it's less safe or unsafe. And how exactly could this have happened safely? And then especially when we're thinking about patients that are populations of color, which is the majority of the patients that we serve here, we also have to deal with the fact that there is earned medical mistrust for a lot of patients and families that interact with us. The other piece that's kind of a more subtle component of that is the lack of long-term safety data. So a lot of families will say, okay, doctor, I totally hear you. You explained to me how they were able to produce this vaccine and not shortcut the science. But like, how do I know long-term that it's safe? And then one of the kind of misinformation things that we see that's still perpetuating amongst our families is that the mRNA vaccines somehow get into your genes and alter your genetic structure. And that one has been a little less pervasive these last couple of weeks. But in the early, like when our 16 to 18-year-olds were getting vaccinated, that came up a lot more. And then the other piece has been additives.
How do you counter that? Just out of curiosity, what's your sort of main narrative for that?
So I actually ask families what they've heard so that I can understand where they're coming from. At the beginning, I would start and explain to them exactly, all right, so they took this mRNA, and this mRNA is actually what makes up the vaccine. Once the mRNA enters your cell, it gets destroyed. All that your body's going to do is react to that. But in doing that, a lot of times I wasn't hearing where patients were coming from. So a lot of families were like, you guys are talking about mRNA, but I don't know what that is. So taking that step back to listen to where families are coming from and also asking what their common sources of information are is also really, really helpful to combat that misinformation in a way that's not where you're explaining above a family's head, but in a way that really meets them where they are so that you actually answer the question at hand and not the one that I've assumed that they have. Does that answer your question, Dr. Schroeder?
Yeah.
And then one of the other things that's been really interesting is for parents, a lot of the parents, they've been, eligible for some time. And they might be very, very enthusiastic about getting their children vaccinated, but less so for themselves, especially for our young adult parents who don't really have a lot of comorbidities or any other issues that might place them at higher risk than the general population. So the way that we've really been trying to handle this is really making space to ask those questions. And we've been fortunate that our census has been down. So in terms of being able to really sit and cultivate that time to have a conversation with the family, it's been a little bit easier. There's a little less time pressure. And one of the things that's been most effective is really sharing my why with families. So I'm really transparent about the fact that even as a pediatrician, I'm a person that has a chronic illness, and there weren't people that had my chronic illness in these trials. So initially I was hesitant until I was able to look at the data for myself and really sift through and have a better understanding. And then that it really came down to the fact that I wanted to protect my elderly mother who lives in my home because I'm seeing patients and I could actually bring illness home to her. And for the parents who have been most hesitant, being able to share the fact that I, as somebody who is part of the medical system, had my own hesitance that I had to overcome, and the rationale for actually getting vaccinated myself has been more effective in kind of nudging those parents that have been more hesitant. And then I think the other piece that Dr. Lee really kind of drilled down on is really being honest about what's unclear and what's clear, because there's still so much nuance about our understanding of how COVID is affecting our populations in terms of our small children, and in terms of thinking about the safety long-term for these vaccines. And then the other piece that's been really effective is highlighting the efficacy of these vaccines in comparison to the ones that have been commonly accepted by patients and families. So for families who have been more hesitant to get their child vaccinated, being able to say that, oh, you know, last year when your child got their Kinrix and their ProQuad, those are actually even less effective than this vaccine that we have here that's available for your child. So being able to also tag on to something that's familiar to families and less threatening has also been really helpful.
Well, thank you for sharing all of that. And Dr. Juvvadi, Dr. Floyd mentioned that the sort of selling point of getting kids to be back to normal, or families wanting their kids to be back to normal, and the vaccine is sort of being a way out. When you were on this seminar series a couple months ago, you spoke about quite a bit about all the mental illness issues, and I think eating disorder issues that many of our particular adolescent patients are seeing. So maybe before you jump into sort of more broadly how things have been going with vaccination, are you seeing any trends one way or the other in that particular issue?
Yeah, thank you. We're still seeing quite a bit of stress and anxiety, and I think I'm seeing more younger kids now. The 7, 8, 9-year-olds that have regressed, that are having sleep issues. I feel like the older adolescents, now that they're immunized and they're back into semi-normal activities, you know, at least with their sports, and for the summer, they have summer camps. And I've been signing a few stay away summer camp forms. So that's very encouraging for these kids. So that I'm seeing a slight improvement in these kids. The eating disorders children, I just saw a huge spike, but now it seems to have plateaued. So that seems very encouraging as well. I just think kids getting out there, they're active, they're seeing each other. So they realize that the other kids have issues too. So I think that's been eye-opening for them instead of being cooped up at home. So yeah, so the older adolescents, I think, are doing slightly better. The younger kids, I think, it started showing symptoms a little bit later of anxiety and stress. And so that I'm still seeing a little bit, which I'm hoping by the fall, when these kids go back to school in person, hopefully will be a little bit improved. But I have a practice that's slightly different in demographics from Baraka's practice. So we see more private payer patients. And so these are the highly educated, everybody's got a master's plus degree in the Silicon Valley. So these parents have a very different perspective. And in fact, in the beginning, when parents were getting the vaccine, they were like, this doesn't feel right. Like all my life, I've been taking care of my child getting the vaccine first. And so this feels somehow unfair that I'm getting the vaccine first. But you know, it took us reminding parents that it's the same as that little oxygen mask that hangs down from an airplane, right? Like you put the mask on yourself first so you can be a better parent and protect your child. So, so I think some of the hesitancy has been, like Baraka mentioned, about the rapidity with which the vaccine came out. But for me, I found what Bonnie had mentioned in one of her talks very, very useful, which is, hey, look at the number of kids, right? In the middle of a pandemic, we have thousands of people that are enrolled in these trials. Whereas if you're talking about polio or measles, we're talking years worth of data that needs to be collected just because there's not that many cases of polio. And so that's been a good point for me to share with families. So that's helped a little bit.
Has there been, I think Dr. Floyd mentioned the concern about the mRNA getting into your cells or your DNA. What has been the most common sort of reason voiced for hesitancy in your population?
I think the most common would probably still be the rapidity with which it came out. The mRNA getting incorporated into your DNA, I'm not hearing that. I feel like perhaps this is a population that actually knows what synthetic mRNA is, or at least has been reading about it, and perhaps the news forums that they read or chat groups that they're part of are slightly different, maybe just because of the demographics. So yeah, I'm not hearing about that. I think what also helps is that, a lot of us are very vocal about, hey, if you take a look at all the MDs in this area, how many MDs have immunized their children? And so if we're feeling comfortable, perhaps that would be reassuring for you. Lately, of course, the myocarditis has been the #1 question that everybody has. And all of them have gotten 1 dose and are chickening out with the 2nd dose. So I think that's probably the #1 concern right now.
Is that something that you think we're seeing throughout pediatric clinics, that people are deferring that 2nd dose?
Yes, they're asking if they should be deferred, because I think particularly in the beginning, for a while there was talk when Pfizer was talking about, should we do a 3-week, 4-week, 6-week 2nd booster dose? And so I think that's kind of stuck in their heads too. So they keep asking if they should postpone that 2nd dose. But and I've been telling them it's safe. A lot of us have had our kids immunized with it. The 2nd dose is perfectly safe. Also providing data about viral myocarditis in general, and talking about, other viral infections that can cause myocarditis. And again, talking about, potentially the long-term effects of having long-haul COVID or something else has been, kind of convincing some of our families.
Great. Sorry. I want to make sure that we try to get to the rest of our questions here. Thank you guys both for sharing, and hopefully you can weigh in on some more of these. Well, first just comment, Dr. Gail Wright, who's a pediatric cardiologist, made a couple comments about that the recommendations for restriction of activity for myocarditis really are for kids who have true bona fide diagnoses. So in other words, don't go looking for it, I think is what Dr. Wright is saying. Don't go looking for it in someone who's asymptomatic. But then also mentioned that, and I think it directed a question to Dr. Lee, who's not here anymore, but it sort of brought up the difference in kind of the severity and the volume of MIS-C cases in children versus what we think we might be seeing, at least with the vaccine-associated myocarditis. So I think those are important numbers to remember. And we had at least 1 kid go on ECMO with MIS-C here, so it can certainly be a nasty condition. And so far, at least, if indeed the signal for myocarditis is real, most of the cases have been pretty self-limited. There have been a number, Dr. Matthew, I'm going to bring you here and see if you can just comment a little bit about where we are on masks. There have been some questions submitted about what kids who are unimmunized can or should be doing. Is it safe to play outside unmasked? Is it safe to go inside with vaccinated people? Lots of different questions embedded in there, but what are your thoughts now on kind of the best way to prevent transmission in younger children?
So I would say that CDC has put out several recommendations on masking. Early, a few weeks back, they came out with the recommendations on what you can do if you're vaccinated. And in that particular document, it said that if you're unvaccinated, basically nothing really changes. So you need to continue to mask, and that would be essentially all our 12 and under. So last week, I believe, CDC sent out another recommendation on what to do in summer camps and for outdoor activities for children or unvaccinated rather, so that the children primarily impacts children primarily. So the recommendation is that if you it's a soft recommendation, but they do allow for unmasking in outdoor and camping areas, but in very specific scenarios. For example, if you're able to maintain the physical distancing, or if the rest of the people in your in the camp are vaccinated. So I'm not entirely sure how this is practically possible to implement. So my general thought on this is that outdoor activities are clearly much less of a risk for transmission compared to indoor, and we have known this all along. So in the outdoor setting, I do think that children are safe. If it's a crowded space, I would say that probably it's a good idea to mask just to be safe. But at the same time, I would imagine there are times when you can unmask. It's hot, and I see my own children having to mask all the time. It's quite, so I'm not sure it's practically possible to keep them masked till a vaccine undergoes a EUA for that age group, which is several months down the line. So that's kind of my practical guidance, is outdoors are probably very safe for children.
Seeing more and more testing opportunities now, and even some home testing, home rapid tests now commercially available for anyone who wants them. Is that something that you would recommend for people that want to get unvaccinated kids together?
I don't think so. So the home tests, particularly the antigen tests, are useful, particularly if you're symptomatic. For asymptomatic testing, what we have run into recently is that we see a lot of false positives, particularly in the vaccinated folks who undergo testing. We were seeing more of false positive results. And so I do think that if we routinely test, that is one of the consequences, is then you'll have to undergo more testing because you're not so sure the test was truly positive. That is not something that I think is very useful.
And at least for my kids' camps, they are requiring testing beforehand, that documentation of negative tests. And I think various schools are considering that option for the fall. Up on that?
As you know, the test, even if you're negative today, you could be positive tomorrow. So but I suppose the thing is, you would, if you're going to a summer camp, it is better to know if someone's positive, even if it's just one or two that you capture. It's a good idea, but I just don't see how that's a useful strategy in general. I just think that you'll get false positives leading to whole families having to get tested. I mean, it's not a simple thing to get a positive result.
Okay. Doctors Juvvadi and Floyd, are you having people coming in requesting testing? And how are you approaching that question?
Yeah, so we do get a lot of questions, and we give the same answer that Roshni has been talking about for a while, which is, if your child is asymptomatic and you're doing a screening test, I would much rather do the NPR test that Stanford offers. And I think the fact that probably more than 85% of my population is on my chart, it simplifies things because I place the order, they can self-schedule. And a lot of them live around the peninsula, so it's easy access for them. And I think there is enough awareness now about the rapid tests not being particularly as useful. And so we've been doing a lot of those pre-camp, pre-travel even, if you're doing local travel to go see grandparents. a lot of them were just doing the NPR through Stanford.
Our situation is similar. Whenever testing is requested, we generally do the NP swabs through Stanford, just because, especially for low-income families, a false positive can be really, really disruptive to a family's work schedule and their overall well-being.
Yeah, and I think an important epidemiologic point that even a specificity from a rapid test that appears quite high, 98, 99%, and prevalence is very low, the positive predictive value is still very, very poor. So getting a test, if in an asymptomatic patient, getting a test with high specificity, ideally near perfect specificity is probably the best route. Let's see, there are a couple of questions here. Dr. Matthews answering that one good. There's a question about whether older patients should get a boost, who receive J&J should get a boost with mRNA. Rajni, I don't know if you want to handle that one. I think generally the advice has been not to mix brands effectively. Is that still the case?
Yes, so there is currently no recommendation to give a boost per se with mRNA after you've received J&J. If a person has received vaccination in another country and it is a WHO approved vaccine, they can either not undergo further vaccination, or they can actually still, if they wish to, can get the Pfizer vaccine, or sorry, one of the approved vaccines in the United States. If they have received a vaccine that is not WHO approved, then it is not counted as vaccinated. So they would need to truly complete the full vaccination within the United States.
And in terms of overlap between Pfizer and Moderna, is that even the same mRNA vehicle? Is that discouraged as well?
That is discouraged as well. The recommendation is to stick with whatever you initially received. But if for any reason it's unavailable, there is a sentence that says that you could, but generally speaking, you're supposed to stick with what you got.
And Raji, just maybe if you can pull your computer a little closer, because I'm not able to hear all of your answers. I'm getting most of it, but it may just be maybe my computer too. There's a comment here that I think many people have expressed over the course of, thinking about how to vaccinate the world and not just the U.S. And I don't know if Raji, you want to comment on this at all, but in terms of taking some of the AstraZeneca and doses, or vaccinating kids first rather than getting vaccines to India. Any comments or reflections on that?
It seems like a solution, but I'm sure that there are several roadblocks that are at way higher levels that prevent such transfer. I can imagine that the mRNA vaccines are complicated to use in countries like India, for example, because of the storage requirements. But even for AstraZeneca, I can imagine that there are several issues that prevent such a transfer to another country. I don't know much more.
And then I just have one more. I think we've covered most of the pre-submitted ones. The question about whether the antibodies from vaccinated breast milk is making it, is conferring immunity to infants. Can you update us on anything we might know about that?
There was a paper that looked at the antibody levels in babies, and I cannot recollect all the information on that, but clearly babies do get transferred antibodies from vaccinated moms. But that's about all I can remember of that paper, but there is something that has been published on this.
Great. Well, I think we've covered everything. So we will close out. Dr. Floyd and Juvvadi, thank you so much for joining us during your busy clinic days. And Dr. Matthews on service, thank you for joining us and taking some time. And thanks everyone for the questions.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. please visit us at med.stanford.edu.